Hi everyone, this is Sarah Rossmessler, and this is a training video for volunteers at the Harmony House, and this one is entitled Care of the Actively Dying Patient. Our objectives for today are to, first and foremost, review the scope and role of the Harmony House volunteer. Second, to define and describe the active dying process. Third, to consider the dying process as multidimensional, including aspects of physical, psychological, social, and spiritual conditions, as well as fourth, to anticipate, understand, and intervene on common symptoms that arise as a person moves through active dying, and lastly, to examine our own beliefs, skills, and boundaries in the service of individualized resident care. So to set the stage and get everyone on the same page, the role and scope of the volunteer at the Harmony House. Volunteers, as you may understand, are surrogate family to our residents. Volunteers who have clinical experience, either social workers, nurses, nursing assistants, or physicians, are asked to act in the role of volunteer, aka surrogate family, not in the role of their professional lives or training. Volunteers without clinical experience are trained for care to residents in the care that they need. So you will all be trained in the skills that you need to provide safe and appropriate care for residents. Harmony House staff are available for questions and concerns at all times, and our residents hospice agency is also available 24/7 for clinical, psychosocial questions as well as support for you. And when in doubt, we want to always encourage you to reach out and don't go it alone. So what is active dying? Dying is this process and highly variable time frame in which someone is reaching the end of their life. Sometimes you'll hear it referred to as imminent death or imminent dying. It is a stereotypical pattern of signs and symptoms in the last days and hours prior to death. We like to understand this trajectory because it can help us tailor care to residents. Somebody who has 14 days to live may be, requesting different kind of care than somebody who's really actively dying in the last 24 hours of their life. So we're going to use different kinds of medicines, different kinds of approaches for symptoms that arise in those different stages. So it helps to know kind of a broad bird's eye view of where we are in the trajectory. Active dying can last from less than 24 hours to as long as 14 days. So that wide spectrum of time frame can be important to recognize so that we're adapting what we're doing for individual residents. Active dying is physical work, psychological work, and spiritual work. So we'll talk about each of these dimensions in a little more detail throughout this lecture. And then I wanted to introduce you to this term called decathection or decathecting. To decathect is to withdraw one's feelings of attachment from a person, idea, or object in anticipation of a future loss. And I think this is a term that I learned only a few years ago and is really helpful for me in just helping to describe what's happening and to notice what's happening as patients are moving through the process of active dying. And like labor in the other end of the spectrum of life, when we characterize the birthing process as labor, the dying process is also can be seen as labor and is work for the patient and the resident to go through all those dimensions. So we'll touch on that a little bit more in the future as well. Active dying has different stages. There's early stage, which is when a patient may be becoming bedbound. They're starting to lose interest and or ability to eat. In the middle stage, there can be further decline in a mental status. A resident may be slow to arouse or only briefly awake throughout the course of the day and night. And then in late stage, it can look more like a coma. There can start to happen some breathing changes, fever sometimes, and what we call noisy breathing, with sometimes is referred to as the death rattle, and then cool or bluish extremities. So these are sort of stages that can happen. It's certainly not predictable, but generally you can see this pattern sort of happen, and it can help you think through how you're going to intervene on the behalf of your resident. I wanted to mention this graphic, which can be helpful in terms of, again, having that bird's eye view. The normal trajectory for a patient that's going through the process of active dying is this road here, this sort of usual road, which is that a person becomes a little bit more sleepy, maybe lethargic, obtunded, which means that they're really not arousing, become semi-comatose, comatose, and then death occurs. This is in contrast to this, what they call the more difficult road, which is sometimes characterized by periods of restlessness, confusion. Sometimes patients can be tremulous, have hallucinations, delirium, some jerking motions, sometimes can lead to seizures, and then eventually you see that it connects back with the usual road where someone is semi-comatose, comatose, and then death occurs. So obviously, there's nothing we can do to predict which road someone's going to go on, but I think it's important to know that both are in fact normal, just different, and it's going to cause us to intervene in different ways. So what are some of the common symptoms that occur during active dying? We already mentioned the loss of interest in eating or drinking. The way we're going to intervene there is to offer but not force food or fluids. And if somebody does not want food or fluids, to provide meticulous mouth care. So we want to make sure that someone's not experiencing a dry mouth or any kind of sense of thirst. Usually the idea of feeling hungry is not active in this process of imminent dying. So we can continue to offer things that are palatable, easy to swallow, like pudding, ice cream, applesauce, things like that. But obviously, if somebody is not interested in those kinds of things, we don't push it. Shortness of breath is something that can occur. It's something we will want to intervene on. Our options here are to give oxygen, supplementation, opioid medicines that can be helpful with both pain and shortness of breath. Repositioning in the bed, if somebody's short of breath, usually the shortness of breath is improved if the head of the bed is elevated or if they're leaning forward, if it's possible, in sort of a what we call a tripod position. And then also having a fan blowing or an open window can be helpful. Residents can also sometimes become disoriented or have hallucinations. This is normal and a part of the natural dying process. Now, we do need to differentiate between hallucinations that are distressing and hallucinations that are either comforting or benign. So this is we're going to take our cues from the resident. So hallucinations that may be benign or actually comforting may be in the form of a vision of a previously deceased family member that's coming to visit. My grandmother is sitting over in the corner, and if it doesn't seem distressing, we leave it to be. We don't try to redirect or correct what they're saying. There's nobody over there in the corner. That's not helpful. On the other hand, if somebody is having distressing symptoms, I see snakes in the bed, or there's something crawling on the walls, that's something we will intervene on with either medication or redirection. So that's something you will want to contact hospice about if that occurs. If they have pain, which oftentimes does go along with advanced disease, you may, if they're able to express their pain verbally, you'll know. If not, we're looking for signs, nonverbal cues that they're having pain, such as groaning, restlessness, or facial grimacing, furrowed brow. Our strategies for intervening when somebody's having pain is to reposition them again, give pain medicine or opioids, something like morphine or oxycodone. If the pain does not resolve with the medicines or the interventions that you've done, that is an indication that you'll want to call hospice and get further advice as to how to ameliorate their pain. Next, moving on to agitation or restlessness. This can be part, as you saw from the two roads towards death, Restlessness or agitation, certainly we can provide reassurance. We can give medicines that are available to us for agitation or anxiety. And if those aren't providing enough comfort for the patient, you want to call hospice. And we're always taking into consideration patient safety. So as much as we want to let things run naturally, we don't want anybody to fall out of bed, break a hip or a leg, or concuss their head. So keeping an eye on someone's restlessness is important as far as their own sense of psychological well-being as well as physical safety. So breathing noisily, and we'll go into this a little bit more in more depth in the next slide. We want to think about repositioning. Sometimes secretions can pool at the back of the throat and cause sort of a, anywhere from a loud snoring noise to a really difficult to listen to noise that can be quite distressing to people who are listening to it. The general consensus is that this death rattle or noisy breathing is not thought to be distressing to the patient because they are in that latter stage of the dying process where they're comatose, semi-comatose, and aren't necessarily feeling the consciousness around what's happening to them physically. Nevertheless, we want to provide reassurance, and sometimes hospice will recommend medications that can help with drying secretions that are pooling in the back of the pharynx. Jerking movements, sometimes we call them myoclonus. That might indicate drug toxicity and is something that we would definitely encourage you to call hospice about if your patient is having either multiple startling kinds of symptoms, or if their arms, legs, or head is twitching repeatedly. That's something we would be concerned about and would warrant a call to hospice. Okay, so breathing changes. I want to go further into this. Mouth breathing oftentimes can happen. People are not breathing through their noses, so their mouth lips become chapped and dry. So that's where we want to provide lip balm and mouth care with mouth swabbing, moistening of the mouth using mouth lubricants. And those are things that you will be trained on how to do safely and with hospice support. If breathing becomes shallow, that's something that we would determine is quite normal in this active stage of dying. On the other hand, if you notice that your resident has labored breathing, that is something we would want to intervene on by giving oxygen, giving an opioid at a low dose, an appropriate dose as directed by hospice, repositioning them, and offering that fan as we mentioned before. And of course, labored breathing might be distressing, so that's something we really want to actively manage. Breathing pauses may occur towards the end of the active dying process, and that is normal. Rapid breathing may indicate either pain or a sense of air hunger. So we'd want to, again, give oxygen, opioid, reposition, and offer the fan. And again, calling hospice if none of those interventions seem to quiet the breathing rate. Slowed breathing, you want to take a look and see whether the patient looks comfortable. And if not, you're going to use the interventions we've talked about already. And we also did talk before about secretions, this noisy breathing or death rattle. We want to assess for the patient's comfort. In some circumstances, if it's really hard to listen to and a family member or a loved one is sitting at bedside, we sometimes can consider treating it so that it's not, a long-lasting memory for the family member. And again, with the dry mouth, oral care, fan, or oxygen. So I wanted to expand our conversation a little bit now to some of the important aspects of personhood as we're thinking about caring for someone in the last hours days or a couple of weeks of their life. Really thinking carefully and deeply about what the resident wants in front of you. Are there important dimensions of this person's life that we can share that is important so that we can provide individualized care that's appropriate for them? Some people may want music, others not so much. Some people, strive to be free from any pain, regardless of whether it may make them sleepy or not. And other people really want to prioritize being awake at the risk of having more pain. So again, it's individualized and unique, and our job is to figure out where the person in front of you kind of falls on the spectrum of what they want. And again, as I mentioned earlier, much like birth, death is a process, right? It is natural and different for all people. So we're trying to bring a sense of uniqueness to each person that we care for at the Harmony House. We're going to consider all the senses, what's in front of them. Does it look really medicalized, or is there something, a window out into a nature scene, or perhaps just drawn curtains to provide a sense of comfort and sort of cave-like, quiet and dark. Each person may want something different, but we're taking a look at what they're hearing, what they're smelling, what kinds of tastes they like, whether or not it's dark or light in the room, etc. And sometimes it's important to think about that residents may want something that we can't imagine wanting ourselves. Like for me, as I envision my deathbed scene, I would want scenes of nature. I would want to be either outside or have an open window. And other people really want quiet, dark, and less light, more darkness. So it doesn't matter what I want, it matters what they want. Okay, so supporting closure and acceptance. Again, we've talked about that dying is highly individualized. It can be related to culture, individual person's preferences, as well as what disease they're dying from. So something like lung disease is going to cause more breathing trouble, whereas somebody with a regional or localized cancer, maybe in their belly, may have more pain and less breathing troubles. But everybody's different, so all of those things should be taken into account. Be mindful of our own perceptions of what does a good death look like and what does a bad death look like, and really trying to move away from this sort of one-size-fits-all methodology that can be quite limiting. I think it's worth mentioning that some residents will never come to be at peace or come to a place of acceptance of their own death, and that's difficult for us to see as caregivers. We want people to come to a place of closure. We want them to be able to complete their life tasks. This book from Ira Byock called The 4 Things That Matter Most is where he suggests that we encourage things like, saying thank you to people, asking or giving forgiveness for things, saying, I love you, those sorts of things. And those, if those are possible, certainly those are beautiful and welcome. But it's also important for us to recognize that that may not be possible for everyone. So we want to be open to it, provide support around it, but also not be judgmental or disappointed if it doesn't happen. So completion of unfinished business, this may be occurring earlier than the active dying process, but if it's possible for people to feel heard, listened to, making sure that things are completed for them, that can be quite therapeutic. Thinking about dying and death as social events is important to expand the idea about who family is, who loved ones are. Is it friends? Are there strained relationships or even enemies that we need to be aware of? Does this resident seem to express that they want companionship? Do they want people in their room? Or are they more isolated and prefer to be alone or solitary? And then again, we're going to try to avoid making assumptions. We're going to see if we can find out what they want or what they prefer. This bird here, sitting by him or herself, does not seem to be unhappy, just a different kind of setting. Not right or wrong, just different. And really thinking about, expanding the idea of who is important to this person is who we also want to include if appropriate in the care and communication. Psychologically, dying, active dying, is this process that can include lots of different emotions. And we need, as care providers, to respond to those emotions. So if there's denial, what are we doing to either help with a sense of acceptance or understanding at the very least? Is there regret that just needs a listening ear to be a part of? Is there worry about things that we can actually reassure a resident about? So all these, I just wanted to, mention all of them or introduce all of them, and then encourage you to think, as you see these things happening, what is it that we are going to do and how are we going to respond to them? Next, we want to think about spiritual or existential elements of the dying process. This is Mother Teresa. You can see her laying her hands on, and that's what, the sort of the amazing and profound things that we'll be doing at the Harmony House, where we are touching the dying, the poor, the lonely, the unwanted, according to the graces we have received. And let us not be ashamed to show or slow to do the humble work. So I just think this is a beautiful vision, and at least for me, is going to be inspirational for the work that I do at Harmony House. We are all spiritual beings. We all have a dimension of our own soul, however that plays out in our lives. Some people, confuse spirituality with religion. Some people are religious but not spiritual. Some people will not key in on the term spirituality. But I think this idea that there is something higher and important about an individual person's life is an important part of caring for them at the end of life and offering possibilities for them to find meaning or closure in their lives, how they may express their spirituality. If they are religious, do they want access to a chaplain through hospice? And is there any proactive planning for rituals before or after their death that is important for them? And again, this is T.S. Eliot's Murder in the Cathedral, a quote that I hold close to my heart as I do work with people and families who are dying, is that this concept of, I am not in danger, I am only near to death. And in hospice and end-of-life care, that's something that I think is an important anchor or grounding place for us as we care for patients. Now, we've talked a lot about things that are natural and normal and routine and part of what we can manage at the Harmony House. And for the most part, 99 or 95% of things will be within that scope. But it is worth mentioning that there are, on rare occasions, emergencies that happen in actively dying. But we want to make sure that you know what to do. Your basic go-to is going to be able to recognize them and then to alert either Harmony House staff or hospice in all of these circumstances. Uncommonly, hospice may, in rare circumstances, ask you to call 911, and that is if there's examples include a resident with active bleeding that won't stop and is distressing to them while you're waiting. If you feel comfortable, this may be an opportunity for you to add compression, dark towels to absorb the blood. And obviously you want to call a hospice. A resident with uncontrolled nausea or vomiting that is really distressing, that's not responding to medications or any interventions, those are things we want to call hospice about and may, I would say they are characterized as an emergency. And then a resident with an abrupt loss of ability to breathe, despite oxygen, opioids, and we want to call hospice for that. There may be something that we are going to do in the emergency department that's not possible at the Harmony House. And lastly, I thought I would mention requests for hastened death. This is somebody saying, can't you give my loved one, or can't you give me enough morphine to bring my death on sooner? I don't want to go through this suffering. And those are things that are outside of the scope of what the volunteer is equipped to be able to handle. So you'll want to ask for help if you get requests like that from your staff, your colleagues, as well as hospice. And that's something I would really encourage you to do. And we want to consider the environment so that we're providing really exceptional and thoughtful end-of-life care for people who are in the active dying process, and really trying to detect and be sensitive to the mood in the house, what's happening outside of the house, what's happening with the weather. Is that impacting the staff? What's the temperature and the lighting like in the room as well as the hallway? And trying to make sure that conversations are quiet, that they're hushed, that the door is closed if sensitive conversations are happening, and really trying to move away from, sort of a medicalized, sterile, bright kind of thing, and move towards a place where it feels homey and safe for the patient and the resident. Signs that death has occurred. I want to reiterate that this is not an emergency, and it is not your job as the volunteer to be sure if a patient has died or not. What we do want you to be able to do is to notice if these things have happened, like a resident not being responsive to touch or voice, not breathing, that you can't detect a heartbeat or a pulse. And again, this is not your job to try to, lay a stethoscope on. It's just that if you have the ability to feel for a pulse and it's not there, their pupils look fixed and dilated, they become pale or lost their muscle tone, it seems like they have died, the next step for you is to call hospice, whether or not it's in the middle of the night or in the middle of the day. First step is to call hospice. You do not call 911. It is not an emergency, and it is not a rush either. So you can take some time to breathe, settle yourself, support the patient and the family, and then make your call over to hospice. After a patient has died, again, not an emergency, hospice needs to be notified, thinking about how this is impacting you as a person. And then you're going to wait for instructions from the staff or the hospice agency. When a patient has died, hospice will make a visit to come for a formal pronouncement of death. And the body will be transported to the funeral home. And postmortem care, or care after a patient has died, is based on the resident preferences, if that's known. But that's not something you would be responsible for providing without instruction from either the Harmony House staff or the hospice agency. So lastly, I wanted to really think about summarizing what it is we're trying to do in the active dying process as we care for patients. We want to know whether there's physical care that needs to happen, whether or not whether quiet presence is wanted or needed. For those residents who are still able to talk and converse, do they need a listening ear? Do their family or friends need a listening ear? Does this person in the bed need advocacy? Do they need support? Should you be activating chaplaincy or helping with final arrangements? And perhaps what they need most of all is space and time without interruption. So drawing the shades, closing the door, giving them quiet and peace as they do their work, their labor of dying. So thank you very much for your attention. I hope this was helpful, and I am looking forward to meeting all of you and working together in this important work at the Harmony House.